For today's presentation, I've put together a brief overview of some of the conditions that I encounter and treat on a day-to-day basis. The heart is the pump that pumps the blood around. It pumps oxygenated blood through a series of pipes called arteries to all areas of the body. The arteries carry oxygen-rich blood to the brain, to the arms, critical organs in the abdomen and pelvis, and also to the legs. Once oxygen has been delivered to the target organ or tissues, the blood makes its way into a different series of pipes called veins. And veins are the pipes that allow the blood to return to the heart and lungs to get new oxygen for the circulation process to continue. There are multiple problems that can affect the veins, but the most common problems affecting the veins are blockages, which cause resistance to vein blood flow, and valve problems, which results in the blood ineffectively flowing through the problem vein. Blockages are typically caused by blood clot within the veins. When blood clot is present in the deep veins, we call this deep vein thrombosis. Thrombosis is a medical term for blood clot, and deep vein refers to the large, centrally located veins in the legs. Blood clots are fairly common. Risk factors for blood clots include being sedentary for prolonged periods of time, which commonly occurs when people go on prolonged plane trips or car rides, traumatic injury, and various genetic or acquired conditions which predispose to easy clotting. If you get a blood clot in a deep vein, then this is generally treated with a blood thinner. In some situations, there may be the option of using clot-busting medications. The other type of problem that can affect the veins in the legs is valve problems. Inside the veins, there are these little flaps of tissue that are shown here, known as vein valves. These flaps of tissue are like one-way gates that constantly open and close, and every time the valve leaflets close, the central part of the valve leaflets come together. And for a variety of reasons, these valves can sometimes stop functioning normally. The most common reason for valve dysfunction is that the vein has become a little stretched out, and the central part of the valve leaflets no longer touch as the valves open and close. The key function of vein valves is to resist the reversal of blood flow, and if those valve leaflets are not touching, then the valve will cease to function effectively. And this results in increased pressure in the vein. And when the pressure in the veins is increased, this can cause a variety of symptoms that I'll touch on in the following slides. Vein valve problems also goes by the name chronic venous insufficiency or venous reflux disease. One key concept to understand when considering vein problems is the difference between deep veins and superficial veins. The deep veins are located in the central portions of the calf and the thigh. The deep veins are larger and generally more important than the superficial veins. The superficial veins are located at the periphery of the leg and are much closer to the skin surface than the deep veins. In most patients, the superficial veins are within an inch or two of the skin surface, but they can be deeper than this in patients who are overweight or obese. The superficial veins carry a smaller percentage of venous blood flow compared to the deep veins. Valves are present in both the deep veins and the superficial veins, and vein valve problems can occur in the deep venous system as well as in the superficial venous system. However, it's much more common for vein valve problems to affect the superficial veins. Vein valve problems are thought to affect at least 25 million Americans, and some studies have put the estimate as high as 30 to 40 million. This condition is twice as common as coronary heart disease and several times more common than peripheral arterial disease. Vein valve problems can affect people of any age, but the likelihood of developing vein valve problems increases with age. Other risk factors include prolonged standing, such as teachers and painters and people who stand on their feet a lot. This condition affects females more than males, I estimate that 70% of the people that I see with this condition are female. But if you consider the national numbers, there are still millions of males who have this condition. Carrying a pregnancy to full term is a risk factor, and a family history of varicose veins or vein problems is a risk factor. In particular, if you have a parent or a sibling with varicose veins, there may be a genetic component at play. Many people with vein valve problems may be asymptomatic and may be unaware that they have vein valve problems. When symptoms are present, symptoms tend to start out as low-grade and pretty nonspecific, and most patients are unaware that the aches and pains may be related to vein issues. Common symptoms include aching, throbbing, heaviness, and early fatigue. These symptoms tend to be worse towards the end of the day, or if you have been on your feet for prolonged periods of time. Symptoms can also get exacerbated by sitting at a desk or in a car or in a plane for long periods of time. Other common symptoms include leg cramps, restless leg symptoms, skin itching, and ankle or lower leg swelling. When I examine a patient's legs and I am trying to ascertain whether there is an underlying vein problem, I look for the following: varicose veins, spider veins, swelling of the ankles, discoloration of the skin between the ankle and the knee, thickening and changes in the texture of the skin between the ankle and the knee. And at the most severe end of the spectrum, the skin can actually break down spontaneously or get easily injured with minimal trauma, particularly around the ankle area. And if you've got a wound around the ankle, particularly in the setting of long-standing swelling or skin discoloration, it's quite likely that this wound is going to be related to vein valve problems. This is what we would call a venous ulcer. The diagnosis of vein problems is heavily dependent on diagnostic ultrasound, which is a painless and non-invasive way of evaluating the structure and the function of the veins in the legs. Ultrasound testing involves placing a handheld ultrasound probe on the skin surface, which shines high-frequency sound waves through the skin into the tissues underneath the skin. And when these sound waves get reflected back, this information gets converted into an ultrasound image, which is displayed on a screen, which allows us to visualize the veins. In addition to seeing the size and the shape of the veins, the ultrasound lets us see how the blood is flowing through the veins, and if the blood is flowing in the wrong direction for longer periods of time than is considered normal, we consider that to be consistent with venous reflux disease. If patients are diagnosed with vein valve problems, there tends to be two broad pathways of treatment. Initially, we tend to recommend conservative therapies, which are non-invasive strategies that can alleviate symptoms without necessarily curing the underlying condition. These strategies include elevating the legs up to several times per day, using compression stockings, performing regular exercise in an effort to get weight under control, and to help use the calf muscle pump, which helps venous blood circulate. There are several procedures that I perform on a daily basis that allow vein problems to be fixed using minimally invasive techniques. The most commonly performed vein procedures leverage the concept that there's a good amount of redundancy built into the venous system, and, surprisingly, there's actually more veins in each leg than the leg needs to survive and thrive. And if the vein valve problem is present in a superficial vein, then this superficial vein can be targeted for procedural intervention. Currently, we do not have procedures that can make vein valves restore function, but we do have the ability to seal problem veins closed, which forces venous blood to flow through alternate, non-damaged vein channels. These procedures are now walk-in, walk-out, and are performed in an appropriately equipped medical office on an outpatient basis. Patients no longer need to go into hospital to have their veins fixed. One of the most common procedures that I perform is called the ClosureFast procedure, which is also known as radiofrequency ablation. This is a quick in-office procedure that normally takes me about 20 to 30 minutes to perform per vein. The procedure works by sliding a radiofrequency catheter into the target vein using ultrasound-guided access into the vein at or slightly below the level of the knee joint. The catheter delivers radiofrequency energy into the wall of the vein, which heats and damages the vein wall, which results in sealing the target vein closed. This brief animation may help conceptualize the procedure. This first portion of the animation shows a normal superficial vein with normal valve function. And this next section of the animation is showing what it looks like when the vein is a little stretched out and the valves are not functioning properly. So this is a problem vein that you want to get rid of. And instead of tying off the vein or surgically removing it, if you seal the vein closed, I am eliminating the problem and blood is naturally redirected into remaining healthy veins. So after accessing the vein at the level of the knee, a thin access sheath gets inserted into the vein. The catheter then gets inserted through the sheath into the vein, and the catheter gets slid up inside the target vein under ultrasound guidance to the level of the upper thigh. The upper portion of this animation shows an ultrasound probe sitting on the skin, which allows visualization of the catheter tip within the vein at the upper portion of the treatment zone. Manual pressure is applied using the ultrasound probe to facilitate compression of the vein as the catheter gets activated. The catheter is activated by pressing a button on the handle of the device. And when the catheter is activated, radiofrequency energy gets released from the active portion of the catheter, which is located right at the end of the catheter. The active tip on the end of the catheter is either 7 centimeters or 3 centimeters in length. Each treatment cycle lasts 20 seconds, and after treating the upper segment of vein, the catheter gets pulled back and the next segment of vein is treated. The wall of the vein is damaged by the heat from the radiofrequency catheter. The vein is then blocked off immediately after the procedure, and over time the vein shrivels, contracts, and becomes a thin string of tissue, well below the skin surface, that is not visible externally and is not noticed by the patient. This procedure has a 99% technical success rate for sealing off the vein and a complication rate that runs about 1 to 2%. There's a new product that came to market in 2015 by the name of VenaSeal. This product is highly effective at sealing the target vein closed, yet is more comfortable than traditional minimally invasive procedures. This procedure involves injecting a microscopic amount of adhesive polymer through a long delivery catheter that's temporarily inserted into the target vein. When the delivery catheter is connected to the delivery device, it kind of looks like a long glue gun. The procedure uses a specially formulated medical adhesive that has been designed and proven safe for administration into humans and allows the target vein to seal within seconds. The adhesive is a polymer that is packaged into a small glass jar. And when you hold the jar in your hand, a couple of things jump out at you. Number one, the jar is really small and contains only 5 mils of adhesive. Now to put that into perspective, it would take 6 of these jars to equal 1 ounce. And this is enough glue to seal off the longest vein in the body. That's how strong this stuff is. Number two, when you tilt the jar to the side, you see that the adhesive is very viscous, kind of like a transparent version of honey. A minuscule amount of glue comes out of the tip of the delivery catheter with each squeeze of the handle on the delivery device. The glue sets rapidly within seconds, similar to superglue. I hold pressure for 3 minutes just to make sure that the vein has really sealed off properly at the upper aspect of the treatment zone, and then as I move down the vein in 3 centimeter segments, I hold pressure for 30 seconds at each segment. This procedure has been FDA approved for a couple of years now and is now covered by Medicare and most of the commercial insurance companies. It has a 99% primary technical success rate and a very low complication rate. And when patients leave after this procedure, they leave with a Band-Aid on their leg, as opposed to a multi-layer compression bandage. In my experience, this product is highly effective at sealing off the target vein and has very high levels of patient satisfaction due to the fact that there is no pain when the adhesive is being delivered into the vein and the fact that patients can return to work and sporting activity immediately. The next procedure I wanted to mention is called Varithena microfoam. The way the Varithena microfoam works is by injecting a specially formulated microfoam into the target vein. The foam is a combination of polidocanol and oxygen, and when I draw it out of the canister, it looks like shaving cream, and this product can be directly injected into the target vein. The foam causes the target vein to spasm and clot, and then subsequently shrivel and regress. This animation is taking you through some of the procedural highlights. I use an ultrasound to put a needle into the target vein, and then through that needle I advance a wire, and over the wire I advance a thin sheath into the vein, and through that sheath I inject the microfoam. The foam has microscopic bubbles that are uniform in size, and as I am injecting the foam tracks along the target vein. I can control where the foam goes by applying manual pressure to the skin surface overlying vein branch points. I can tell when the foam is working based upon ultrasound. I can see that the foam is arresting the flow of blood, and this video is showing the foam flowing through the target vein. The foam works by damaging the endothelial cells on the internal lining of the target vein. When the cells of the internal lining of the target vein get damaged, the integrity of the cells is compromised, and this causes the veins to occlude, regress, and eventually shrivel up. The problematic vein that is treated with foam will seal off immediately and then slowly regress and disappear over the course of a few weeks. There's another procedure that I regularly perform called phlebectomy. It's basically a form of treatment for large ropey veins on the legs, and these veins are difficult to treat with foam or radiofrequency ablation. This procedure involves injecting numbing medicine into the skin and the tissues underneath the skin, and then making a tiny puncture in the skin with a needle, and then using a bent needle or a tiny hook to pull the vein out from underneath the skin. Once the vein has been partially pulled out through the micro-incision, the vein is grasped with a hemostat, and manual pressure is used to tease and pull out as much of the vein as possible. The vein always breaks at some stage. The goal is to get as many veins out using the smallest incisions and the fewest number of incisions as humanly possible. A common question I get is, what stops the bleeding at the sites where the vein tears when phlebectomy is performed? Well, the answer to this is that prior to pulling the vein out, I inject a bunch of numbing medicine that also has trace amounts of epinephrine in the solution, and this medicine causes compression and spasm of the remaining vein segments. And it is this compression and spasm that prevents bleeding from occurring at the phlebectomy incision sites. The procedure works very effectively, and because you're able to pull the problem vein out through a tiny incision that measures maybe 2 to 3 millimeters in diameter, there's minimal scarring. And finally, there's another procedure that I do in my office many times per week called sclerotherapy. What sclerotherapy is injection of medicine into smaller spider and varicose veins using a tiny needle that is similar in size to an acupuncture needle. The medicine used for sclerotherapy causes the vein to contract, shrivel, and slowly fade. The procedure takes about 15 to 20 minutes to perform, and in my opinion, is an order of magnitude less invasive than other procedures I've been talking about. So that concludes Leg Vein Problems 101. Hopefully this talk has provided a little bit of perspective on some of the common problems that can affect the veins and has provided an insightful overview about what some of the treatment options are. Thank you.